The article that I elected to review for this project is a Huber article that was published in volume 45 of Current Problems in Diagnostic Imaging in 2016, and it was titled Early Experience with Implementation of a Commercial Decision Support Product for Image Order Entry. Now, this particular article aligns really well with my research interests in that they worked with the American College of Radiology's appropriateness criteria, which are evidence-based image ordering guidelines, and essentially worked to implement that into their practice and then to see and determine what types of overutilizations or misuse of imaging studies were actually happening within a given facility. Clinical decision support tools and guidelines have only really recently began to gain traction, and that's largely because their use has become mandated by the federal government starting in 2017. Currently, there's really not a ton of information about how to actually implement these types of systems out. So this study sought essentially to say, all right, we're going to take this one, we're going to apply it to our facility, and we're going to then report back. So really, they use kind of a case study approach. But these types of clinical decision support systems, like I said, they're really becoming much more popular. In the American College of Radiology, the ACR has really been lobbying for years to get these types of systems in place to really enhance the value of radiology services, to make sure that equipment and procedures are used appropriately for a given clinical indication. And this can also be then tied back to MIPA, which is the Medicare Improvements for Patients and Providers Act of 2008, which really started to look more at the notion of quality rather than quantity. So the continued theme really is the idea of quality then, and that's what the ACR-AC or American College of Radiology's appropriateness criteria is all about, essentially giving physicians a tool to be able to quickly make a decision about whether a given exam is appropriate for a given clinical scenario. So these evidence-based documents have been vetted by multidisciplinary teams. They incorporate literature, they incorporate practice guidelines, white papers. So really they've been vetted essentially by the profession as being a acceptable tool to essentially say, yes, this is good, no, this is not. No, I would recommend utilizing this tool for this indication. We'll talk a little bit more about the scoring system and how that's essentially derived going forward. But these guidelines have been around since 1990. They started as in the paper form, subsequently have been digitized, and now even are capable of being coupled to electronic health records, which really is what this study goes into, is that how can we take the information, tie it to our electronic health record, and then really first see what's going on in our facilities, and then how can we improve from that. Now, the scoring system is outlined here, and you can see what that scoring system looks like. So it utilizes a 1 through 9 system, with the most appropriate indication being those that score between a 7 or 9 for a given clinical indication. So say it's a 7 through a 9, that's a study that you could proceed forward with based on the guidelines, based on the evidence that's at hand. As being an acceptable option. You may not want to do that with a 4 through 6, and basically a 1 through 3 is saying you need to select a different procedure. This just isn't the right one for this particular indication based on this particular patient. So it gives you more than essentially a given number. There's several essentially pieces of information that it's capable of revealing beyond just, hey, here's a number, here's a procedure, but it can provide information about radiation dose that's associated with that given modality or procedure. So as a comparison that way, and it also allows for cost comparisons between procedures. So there's some interesting literature kind of out there about comparisons about whether, hey, if you're presented with cost, how does that influence the decision making if you're presented with the radiation dose first, how does that influence decision making? So, that's kind of outside of the nature of what this particular project was all about. But there's a lot of great information that can be gleaned from these essentially clinical decision support systems. Now, there's really three commercially available clinical decision support systems, and those three are here. And you can see, of course, that the ACR Select version is going to be one that, of course, readily incorporates the use of the American College of Radiology's appropriateness criteria. But actually, all three systems here make use of it, really showing you the value of this particular tool and kind of how important it is for the field when you have all of these different vendors kind of be utilizing the same base. It says, hey, this is something that we should be utilizing as a profession across all provider disciplines. What's also great about these systems is that they all also allow for order data tracking, so essentially determining what's appropriate, what's not, and being able to generate some reports back on what's actually happening in that facility, what given how many orders are happening, where are those orders happening, so what modalities are they taking place, what specialists are ordering what modalities. So really a ton of information then can be packed into saying, all right, what practices are ordering the most appropriate exams, and maybe perhaps what group of specialists are not ordering exams that are appropriate. So it makes a lot of sense. And when you start to look at appropriateness, which is really my primary topic, this system is something that I think we really truly need to start to look at, I think, as a whole, and making sure that professionals are aware of it and that essentially these systems are utilized to their maximum capacities. So in this study, they did make use of the ACR Select options. In the ACR Select Clinical Decision Support Platform has three separate modes. So it allows the operators to be able to utilize the system in silent mode, feedback mode, or denial mode. Some of the information about the descriptions are essentially there. Really, the vast amount of this study was implemented in the silent mode, and I would really look at this study as, like I said before, as being a case study. Essentially, it's their initial perspective. I really think that there's probably going to be a follow-up to this study because they did implement the feedback mode beyond that, so I think that there is going to be some comparison information that's going to be possible. Now that, hey, we're not just collecting information based on the given indication, but we're providing feedback once these orders are established. We're giving a score. We're allowing the provider to look at the essentially the given pieces of evidence, and then saying, all right, what other alternate options may be available, and allowing those to be considered at that point as well. Denial mode is something that they really didn't get into in this particular study, but essentially it prevents poorly indicated exams from even being ordered. So anything that goes back to 1 through 3 essentially is shut off. It says, no, you can't order this. You have to select something else. So it's in terms of adoption of that particular approach based on, providers' needs, providers' preferences, desires, may not be as well received. So essentially the selection of silent mode was selected initially for this study. Now, this study did take place through the University of Virginia's medical systems. Like I said, they utilized ACR Select. They coupled that directly into the electronic health records, so it wasn't using separate systems, separate languages, separate tools, but essentially the same device integrated into the ordering system. So it allows you to essentially directly collect information based on the orders that are being placed. Now, initially how they phrase things within their given study is that they started off in silent mode, and you can see that they went through this for about a 6-month period before essentially then going to feedback mode. But like I said, the majority of the data that's reported out did take place in silent mode. The sample that was used was ordering providers, specifically those that placed adult inpatient orders or emergency department-based orders in, again, focusing on adults and not pediatric populations. So as far as the providers go, residents, attending physicians, physician's assistants and nurse practitioners were all considered. And for my particular research interest, which is appropriateness of imaging procedures amongst family practice nurses, somewhat, continues to kind of align within this population, being that nurse practitioners were, in fact, included in this particular study. Results are reported here, and you can see that, yeah, they have quite a volume of imaging exams performed. And I'm going to say that really the reports are not as thorough as I initially anticipated, in that they only reported CT scans, MRI scans, and ultrasound, but they didn't report out as far as projectional radiography, so traditional X-rays, nuclear medicine, fluoroscopy studies, interventional-based studies. So, kind of the whole spectrum of medical imaging wasn't necessarily reported out within this particular study, but nonetheless, there are quite a bit of data points that are going to be gleaned from this information. Now, one of the more unfortunate things was that a lot of these studies essentially were useless. They didn't provide the information that was necessary, and that providers were able to essentially order those information. So even though they were quote unquote utilizing the clinical decision system, they weren't required to actually put in the specific indication, or if that specific indication wasn't found, they could free text it, and then the free text wasn't essentially recoded back out to a specific indication. So essentially all of that data and information was not used, which I think is kind of interesting when you think, hey, the government's going to say, hey, everybody has to utilize these in 2017, and then to see that many studies that are not even able to be scored for this particular study, I think is quite interesting. But nonetheless, they did have just over 14,000 imaging studies that had enough data to allow for scoring, and you can kind of see where they fell. And again, just as a reminder, 7 through 9 is the recommended studies. So 65% of the studies that were ordered that had enough information were well indicated. 22 were partially indicated, meaning that, yeah, they may have been okay, just depending on, exactly how the clinical presentation was. But 13% of the studies that were ordered were essentially not indicated for those given positions. So when you start to track that down into, all right, so 13%, so how many patients were unnecessarily exposed, or how many patients then were unnecessarily billed for what could result into some expensive procedures, especially if we tie that back to MRI or CT, sonography or ultrasound tends to be a little bit cheaper. But when you look at those indications, those are some things that the data is telling us. So appropriateness all ultimately really goes back to those factors, but it's how are we utilizing our technology? Are we making sure that we're not subjecting our patients to things they really don't need? So 13% in this study were subjected to tests that they really didn't need. So then Huber and his colleagues then further broke down that information based on essentially given specialists, and I've included some of those specialists in here. Again, it's not looking at everything. It's only looking at inpatients, so it's not looking at outpatients. So even the family medicine based statistics, where you think, hey, these patients are probably outpatient, these are just tying them back to inpatient procedures. So you can kind of look at it, it is what it is, type of thing. Some things for inpatients are going to matter more than others. Internal medicine, for example, is going to be a really important specialty area. But you can kind of see where they kind of filter out as far as not indicated versus the indicated procedures. And approximately 10% were inappropriate across all departments, and it did not vary statistically at a statistically significant level, meaning that everybody is pretty much doing the same based on the images that they could score. Now, if they could have scored all 55,000 of those images, who knows what the results would have looked like if they actually would have perhaps trained the physicians appropriately, making sure that they understand, hey, we're really looking at this right now. We really want you to try to give this system a go. This is how to use the system. This is the value of the system. If that training was kind of in place at the beginning, hopefully, they would have had more data points and they could have raised the N value and got, a little bit more clear picture of some of the information here. And it may have came out exactly the same, but you just don't know. But nonetheless, you can kind of see where those areas kind of rest there respectively. So, really, like I said, Huber approached this through the use of that silent mode and not as far as the case study based on, feedback mode or the denial mode. So really kind of that low level, type of approach was used, really superficial. Let's introduce our physicians to essentially what this tool is, get them familiar with inputting the given indications, and then, expand it beyond that. But as far as kind of, why this information matters, really points that I've touched on already. So radiation exposure, patient anxiety. So if they get, false positives or have to get follow-up testing, that's going to increase their anxiety. Of course, costs are important. Risk that's associated with incidental findings. So you can kind of think about biopsies, and then from biopsies, you can then go into, iatrogenic infections or nosocomial infections or anything else that may kind of come up throughout that process as well. But what was kind of interesting in the discussion, where it was discussion that, hey, pre-authorizations may go away if these systems can prove their value. So if physicians start to utilize these things appropriately, which are important, these guidelines are there to help the profession. They're developed by individuals that are a part of the profession, which is really important when you're looking at essentially big picture guidelines. Is that you want your leaders of your field to essentially be telling you what to do, rather than some other organization. So the fact that we can utilize these guidelines, but yet they're not either being utilized, kind of really as evidence that, hey, only 74% of the studies we couldn't even use because these guidelines weren't even particularly followed. Or if you look at the actual percentages for what was inappropriate, they weren't followed there. So I think it's just really important to utilize that. And, fortunately, what this study did show was that the approach of kind of phasing things in slowly with the silent mode was an appropriate approach to help eliminate some of the negative experiences by physicians. So it's really that ease-in approach in order to kind of gain that buy-in initially. Now, collectively, though, there are quite a few weaknesses that were a part of this study, in that really you could tell that it was preliminary results. They had enough foresight to be able to say, hey, we're going to try this in silent mode. We're going to collect a ton of information. We're going to see what happens. But like I said before, I really think they're going to take this information and follow up with it and say, all right, now here's what happens, when you go from silent mode to feedback mode, not only with, favorability or usability of the system, but then also with the outcomes when essentially that feedback is given and said, hey, you want to try this one. I bet you'll probably start to see a real indication that those inappropriately ordered exams are probably going to diminish substantially once this information starts to become used. Yes, it seems like you can still bypass the system, but nonetheless, I really think there would be improvements. It would have been additionally helpful if there would have been more of a true pre-post. So even before silent mode was even used, perhaps saying, all right, what's actually going on, how often are guidelines being used within a given facility, and kind of looking at it that way rather than, just kind of jumping in and saying you're using it, and not kind of looking at it big picture. Additionally, it was a single center or a one institution based study. Not that you can't get a lot of information there, but practices are going to differ from location to location, physician to physician. So that's, I think, important. Limited percentage of scored exams. I mentioned the idea of training and trying to get the physicians on board initially may have been a helpful approach. One of the bigger weaknesses I think of this study was that there really wasn't a break. There was a breakdown by specialty area. So, like I showed you, internal medicine versus family practice, but there wasn't a breakdown based on the different providers, which I think is really important. Especially at least for my topic, we're focusing on the nurse practitioner based population, just to be able to have a little bit more information about what is how often are they using the guidelines? Are they using them better with a better adherence rate than residents or than attending physicians, for example? The answer could be yes, it could be no. But without kind of providing that information and breaking it down, it's hard to know. Additionally, I mentioned that they only considered 3 modalities instead of all modalities. So when you start to look at those guidelines, they don't just recommend those 3 modalities. Sometimes one a completely different modality is going to be recommended, and it may be very low dose associated with just regular diagnostic projectional radiography and just regular X-rays. Which is super low dose in comparison to a CT scan, for example, and much cheaper than really anything else as well. When you look at kind of that cost factor, narrow patient population was used, and then of course there's nothing wrong with the case study based approach, but essentially the statistical analysis was really really basic. With the traditional averages. Averages were really the only reported based statistics out of this. So as far as looking at that statistical significance, really at least what they reported was that there wasn't any there wasn't statistically significant differences between providers, but they also didn't run any quantitative based measures to be able to say that with more certainty. Given strengths, you can see some of this information is here. Vital information given back in that there really isn't a lot that says even, hey, you may want to try to ease it in. We got buy-in here. I think this is a good way to get providers to start to utilize the system. But even if it's running in silent mode, essentially you at least have something to help form an intervention with, to gather information, say here's where we need to do some retraining, or this is the group to initially target for that retraining. So I think a lot of information can be gleaned from essentially their approach that they took. So I did think that was a helpful suggestion. Wide scale approach being that they didn't just focus on one provider group. They didn't just look at internal medicine and internal medicine alone, but kind of breaking it down by the different specialties could have been helpful. Yeah, and it may have been helpful, kind of looking at it. And if they would have ran different tests, they may have found different answers than just regular means and saying, oh yeah, they're all about 10%. Other ideas is that it demonstrated the importance of collection of pertinent patient information, so making sure that all information was available. That way you can use as many of those data points as possible, but also demonstrated the importance of provider training in order to say, hey, this really matters. Really try your best to try to put an indication in there, and here are the reasons why. So I think it definitely had some strengths. It definitely had a lot of good information. I think some of the information just could have been presented in a little bit different way or analyzed in a different way as well. So overall, as far as study of improvements, changing it from a case study based approach to perhaps comparing different providers, or even splitting off and forming two groups amongst those providers, and seeing what the differences are, leaving one group in silent mode and switching another group to feedback mode, or keeping one in feedback mode and then putting another one in hard stop mode, and seeing kind of what the results look like depending on what you're looking for. If it's provider satisfaction with a system, that hard stop mode probably isn't the right one to use, but I really think that the feedback mode demonstrates a lot of promise within this particular system. More structured implementation to utilize for data points, pre-post analysis, like I mentioned, some more detailed statistical testing. If we could get a provider breakdown based on specialists, based on years of experience, I think that would be helpful as well, just to see some of those differences. Perhaps the younger providers are doing a better job than some of the older providers because of more recent training practices, or maybe it's the older providers that are doing a much better job because of their years of experience. So without kind of looking at it through a variety of different demographic factors, it's hard to kind of utilize this information. So I think there could have been a lot more value collected. They had a lot of data points that I think that could have been useful, and kind of reported out in a variety of different ways. So then information about the exams being ordered inappropriately as well. So it's, maybe it comes down to all of those inappropriate responses were really CT exams. And, maybe we need to have education about when to use CT and when not to use CT based scanning exams and approaches. So again, I think it's a good base. It is a good starting point. I'm glad I looked at this particular article, because I don't think that there's a lot out there just about how to actually utilize ACR-AC clinical decision support systems, and I just think that they're really important to start to utilize, and really that helps to form a lot of some of the base of that research that I'm looking to do kind of going forward as well. So thank you so much for listening to my presentation. I certainly appreciate it, and have a great day.